morning.
Good morning.
How are you?
Take yourself.
I got a whole mess over here. Let me just explain. If I look discombobulated, that is why. I have two laptops running. One laptop doesn't show me what the other laptop has, what I need for today. I have a monitor, the iPad, the phone. It's a mess. But good morning. We're here.
We're gonna make it work.
We gonna make this work. How are you?
I'm great.
How was your holiday?
It was nice. How about yours?
It was good. I keep telling my children who still reside here that they bamboozled me into cooking. They were like, "Oh, mommy, we just want some nostalgia." Really? Can we watch the Macy's Thanksgiving Day parade? Really? So how am I supposed to watch the parade with you and cook all this food? Help make it make sense. So of course I'm in the kitchen all by myself. Everybody's enjoying themselves, laughing, ha ha ha. Really? I said I got bamboozled. But they were happy. So yeah. So how was yours? Everything good? Did you have a
Yes.
good? I can't wait till the meeting. After the meeting, you know I have to plug that. Because I know it's going to be the bomb. Good morning, Renita. Let's go. Really? Let's go, Michigan? Okay.
Ooh.
Right. I feel shots fired. I feel shots fired. Now, even though I went to the University of Cincinnati, I teach at Ohio State. Don't do that. What we won't do. She's laughing. And good morning, Crafty Coder, our on the street correspondent. Love it. All right. Let's get this part. Oh, well, look, I'm looking for notes. No notes on this computer, so might as well just look down. So if you see me looking down, that's why, because I have a whole laptop in my lap working. Okay. I don't know. Like my notes, like the notes that I send you, they're not updated on this. Everything is on the same system, so I don't understand. I'm trying to understand what's wrong with this. What's wrong with this laptop, and why are you playing? Why
Did you update it?
Yes.
So
everybody else is in sync. You know, I'm a whole Mac family. Everybody else in here is in sync, but this little special one right here, I don't know. She just want to play with me today. I got something for her though. But anyway, welcome everyone to our Saturday morning tea, where we discuss health information, news, education, certification, entrepreneurship. I really don't have much on the AMA today, so we won't really get in a business. I think they were enjoying their holidays. The revenue cycle at large. And as you come in, don't forget to hit the thumbs up and or like button. I'm Clarice Warner, the girl with the pearls, the founder and senior education director of the Professional Reimbursement Network, LLC, where coding education is key. And PRN is a healthcare consultancy that's located in Cincinnati, Ohio, that specializes in revenue cycle and regulatory compliance and education. So let me ask you on this education tip. Do you know what it takes to be a certified marketable medical coder? Do you? Well, if you don't, if you've been rocking with us for a while, you should know it by now. But if you don't and you're brand new, and welcome. Before I introduce my co-host, let me share with you information on a free, yes, free. It's not Black Friday free. It's not, what is it today? Small Business Saturday free. It's not even Cyber Monday free. It's free all the time. A free email course on the 5 steps to become a certified marketable medical coder. Are you interested in medical coding, but not sure where to start and scared of wasting time and resources? Let me help you with the right steps to become a certified marketable medical coder. Learn more at bit.ly/5stepscoder. I get caught up. So if you are interested in getting more information on the free email course on how to become, or on the 5 steps to become a certified marketable medical coder, then check out the description box. The link is there. I promise you. I know it's a lot of information, but the link is there. So check it out. So joining me today is my illustrious co-host, Mr. Jesse, the registered trademark. Put some respect on his name, the coding nurse. Sir, introduce yourself and tell the folks all about you.
Good morning, everybody. My name is Jesse. I live in Philadelphia, Pennsylvania. I have been a nurse for 30 years, and I transitioned away from the bedside in 2014. During the pandemic in 2020, I created a company called the Coding Nurse LLC, where I help nurses and other clinicians with a clinical background transition into the wonderful world of HIM.
Oh, and how wonderful it is. How wonderful it is. Let me just, remark on the whole lighting situation you got going on here. The chair, the background. Sir, you better get it. I love it.
I finally, because I had this
Upgrading at its best. I love it.
this big lamp. It was nice. It had the little filter box and everything. That thing, it died, and I spent all that money. So I went to Amazon. I got a $17 light, and it's giving what it's giving.
It is, and it's giving. It is giving, sir. It is giving all of the things. Sometimes it don't take a whole lot. Yeah, it's the whole ambience. Exactly. The whole ambience. I'm feeling it all. I'm feeling it. I feel like I need to go put on a suit. Wait a minute.
This is a preview for 2024. We getting it.
Hey, sir. Yes, I'm loving it. I'm loving it. Okay. So I just had to make that mention. So before we jump in, let me remind you that we bring the topics, but we're about a discussion and a conversation, and just getting to know your opinion on the things that we bring. We hear some of the discussions in the street. We know that some of these topics may pop up in other places, but we don't hear your voice. And that's why we bring them here. One, to give our opinion, because, my co-host is very opinionated and I love it. But we also want to hear from you. We want to know what you think about this, and how it impacts you in wherever you are in the world of health information. So feel free to jump in. You know how to jump in, hit in, and get into these comments. If it's a question, please put a Q in front of it so that we know it's a question, so we can make sure that we answer you. So for those who are joining or watching the replay today, we are talking the E&M visit complexity code and clarification on the split shared visit guidelines. I've been seeing this swirl up and pop up, and I'm like, okay, wait a minute, let's dive deeper. Let's give some folks some stuff that they need to hear about this. But before I get into that, let's get into this. Let's get into this. My church announcement. Yes.
The last Sunday in November.
Yes. Y'all better get it right. Get it right. We got a few more Sundays to get it right. Come on down. Come on down. Yes. Got the us fingers. Love it. Okay. So I really don't have much in the way of church announcements today. I just want, and I know she's not watching because it's an hour behind and she's probably in the bed and all of the things, but I got a doctor, y'all. I got a doctor. So my daughter defended her dissertation on Wednesday night, and it was all the things. It was beautiful. We were all there via Zoom. We got to speak. Why did I have to pull out my whole uh, public health hat and I had to be part of the dialogue? Like, wait a minute, from a public health perspective, but I was like, oh wait, push back. This ain't nothing to do with me. Even though I always say I share that PhD because I work probably just as hard with her. So, but I got a doctor, so I'm excited. So that was my church announcement.
Congratulations.
Thank you. Thank you. I'm excited for her. And so everybody in the family, her sister and brother have been calling her Dr. Sis. I call her Dr. Daughter. It's crazy. So yeah, that's my church announcement. Do you guys have any church announcements? Let me check and see what's happening in the world. Thank you. Thank you. Yay. Yay. We got another one. We got another one. Hey. Okay. Well, child, let's get into this. This E&M code. So last week I mentioned that HCPCS were released at the top of this month. And in the HCPCS code was this evaluation and management, this additional evaluation and management code or code that can be used for evaluation and management. Good morning, Vicki. Welcome. But it's actually a HCPCS code. So CMS then threw their hands in the hat. Now, the one thing about this is the creation of this code has been going on for years, actually since I think 2018. So they not new to this. They've been trying to be true. And if you've noticed here lately within the last several years, they have slowly, in conjunction with like the AMA and other groups, slowly filtered out and dripped, as I like to call it, information and coding changes related to E&M. We had the big change on how we document and decide what the level of E&M services are in 2021 with the office and other outpatient services codes. And then earlier this year, we had, the information related to inpatient services and the other sections and the emergency department. So all of this has been kind of a multi-year endeavor for CMS and the other parties. Well, as a result of that, in the final year or the final rule for calendar year 2024, they've come out and decided to release some more information on E&M. One is around the office and other outpatient E&M visit complexity add-on code, which is I wrote it down. G2211 is the actual HCPCS code. And then the other thing that they have added in that final rule was the definition for split or shared visits, which they were going to do last year, but they delayed it. And so here we are this year with the information. So a little background on, I think I can get rid of this computer. Look, I told you I'm in computer hell. Okay. So a little background on what is happening out here in these evaluation and management streets. So they were looking to, so E&M services by themselves make up a lot of the money that is spent from Medicare and Medicaid for a good bulk of practitioners. A lot of the practitioners, especially specialists, they too can use E&M because if they have a procedure and then they have the follow-up visits and all of those things, so they get it, but they get a bump because they provide services. Most primary care practitioners or physicians, I'm sorry. Let me get it right, Lord. I don't want to get in trouble with the mess. They don't get that bump. They don't get that same love. Unfortunately, they are stuck with just your typical, what they can do as far as the E&M services. And CMS has recognized that. And they were like, well, no, because sometimes they spend the intensity of the services that they are providing through E&M cost money in practice expense, cost money in time, cost money in resources. And so they wanted to find a way to evaluate and compensate those practitioners for that particular work. So I applaud CMS on understanding and realizing that it's an imbalance and there was a need to kind of regulate that. Well, that's where code G2211 comes in. Again, it's a HCPCS code, and it's used to describe intensity and complexity inherent to office and other outpatient services, E&M visits associated with medical care services that serve as the continuing focal point for all needed healthcare services and or with medical care services that are part of an ongoing care related to a patient's single, serious, or complex condition. So that's the whole piece of it in a nutshell. However, folks, folks were in their feelings and trying to understand, and I have, but they had some valid comments. So, when they publish the proposed rule, they offer an opportunity for people to write comments. We talk about that all the time. I tell you, if you see something and you have comments, write comments. Again, they have staff. This is what they do all day. Well, not all day, but this is what they do. They go through, they read those comments, they combine the data and the information, and they respond. And all of those responses are listed in the Federal Register. So they will say, okay, such and such and such. In some instances, they will put like specifics, like somebody, if it's a large group of folks saying the same thing, they will put, because I think they put the med pack in here. And then they'll say, certain practitioners, or I think once or twice I actually saw somebody's whole full name. And I said, well, wait a minute, they must have said something. But I think they were tied specifically to the comments. So, but they do let you know that they have read, they've listened. Sometimes they make changes as relate, and as they did in this case. And sometimes they be like, and we thank you for your comments. However, we sticking 10 toes down. This is what we going to do. And that's what they do. But it's, again, good to know that they are listening and that they hear you and want to provide information. So this particular code, as I mentioned, had been swirling for a while, and it was delayed by the Consolidated Appropriations Act of 2021, or the CAA, before it was implemented. And so because of that, they felt that this particular code could be reported with all office and outpatient E&M visit levels. There was some discussion on, which ones should get it. Should it only be for new patients? Should it only be for established patients? And they have decided that no, this one is good for all, but it's not for every visit. So it really should only be used when there is additional complexity that is, of course, present in that particular visit, and the magic word, documented about that particular visit in the medical record. So, as with all things, that's probably where things is going to be all tripped up. You know how folks don't necessarily like to document things the way they're supposed to be. And Mr. Jesse, you feel free to jump in at any time. So again, it's an add-on code. You would list this in addition to office and outpatient evaluation and management visit, either new or established. The other thing is, this code is not to be used with other evaluation and management codes that are reported with payment modifiers, such as modifier 25. So that this add-on code is again strictly about the visit, and we'll talk a little bit more about what that means as it relates to adding this code, but it's about that particular visit. Modifier 25 is about separately identifiable services on the same day as another visit or procedure. So you're getting credit for the work done, E&M work done around another visit or another procedure that is done on the same day. This is for just the one visit period, and the work and time and resources that you spent with this patient on this particular visit. Right. And it doesn't. So none of, wait a minute, I'm trying to get to her. You're absolutely correct. So none of the payment modifiers, 24, 25, 57, I think is the other one. None of those would can be used for when in addition to this particular code. So they wanted to put that out there. So another thing I wanted to mention, to keep you from reading all 50 pages related to this, but you could always go back and, it's in black and white. And the link to the Federal Register is in the description. They believed that the office and other outpatient, and they call it, well, when you see it abbreviated, it's O/O E/M visit complexity. That's what it looks like. So it reflects the time, intensity, and practice expense resources involved when practitioners furnish the kinds of office and outpatient E&M visit services that enable them to build longitudinal relationships with all patients. That is, not only those patients who have a chronic condition or single high-risk disease, and to address the majority of a patient's healthcare needs with consistency and continuity over longer periods of time. The HCPCS code descriptor so they made some changes to the descriptor to clarify that the code applies to a serious condition rather than to any single condition. But the key piece to this is the relationship and building the relationship between that practitioner and that patient. There are some wonderful examples in the final rule that kind of talks about what that looks like, and I would be interested to see how they're gonna handle that on the back end with auditing and monitoring it. So they also mentioned it's a furthermore, in contrast to situations where the patient's overall ongoing care is being managed, monitored, and or observed by a specialist for a particular disease condition, they continue to believe that there are many visits with new or established patients where the office and other outpatient E&M visit complexity add-on code would not be appropriately reported, such as when the care furnished during the office or outpatient E&M visit is provided by a professional whose relationship with the patient is of a discrete, routine, or time-limited nature, such as, but not limited to, a mole removal or referral to a physician for removal of a mole, for treatment of a simple virus, for counseling related to seasonal allergies, initial onset gastroesophageal reflux disease, treatment of a fracture, and where comorbidities are either not present or not addressed, and or when the billing practitioner has not taken responsibility for ongoing medical care for that particular patient with consistency and continuity over time, or does not plan to take responsibility for subsequent ongoing medical care for that particular patient with consistency and continuity. Again, they're stressing it's about the relationship with that provider and that patient around that disease. So you're providing additional, and I'll get to, I don't want to butcher it, but I'll get to the actual comments that they made regarding stressing that it's the relationship. But before I go there, Mr. Jesse, did you have anything you want to add? Yeah.
Absolutely not. You know, I don't know crap about outpatient.
Oh my God. And you know what? I thought about that, and I was like, I need to pull in the ICD-10 guidelines and the changes, and so we'll do that next week.
No. Because no, outpatient is just as important as
It
inpatient.
is. It is. But I was like, so yeah.
What we know, look, even the government says people have been playing with the church's money when it comes to E&M for
For
ages.
years.
So it definitely
Decades.
warrants explanation. So
Yes.
I'm fine with it because I'm
Okay.
learning.
Okay. So, one of the questions that came in or that they had to address was, and this was from the MedPAC. They noted that CMS had added several services that describe services related to the provisions of longitudinal comprehensive care, including care management or other non-face-to-face services. For example, chronic care management, principal care management, responding to patient portal messages, and remote patient monitoring. So these are all relatively recent, within the past 5-7 years, services that have been added by CMS that, according to MedPAC, they felt were kind of similar to the proposed complexity add-on code. And so they commented, they also questioned how the proposed complexity add-on code would reflect additional work intensity resulting from concurrently addressing multiple health complaints in a single visit, additional clinical staff time or supplies expended during a visit, or additional non-face-to-face activities associated with furnishing comprehensive longitudinal care. Some commenters even went further to assert that the code is duplicative and stated that the selection of visit level by medical decision-making and or total time on the date of the encounter is flexible enough to address patient visit complexity requiring unusual resources. Their response was they appreciate the concerns raised by MedPAC and the other commenters, and they strongly agree with MedPAC and others who state it is important to clarify what specific additional resources this code would better account for compared to the current available coding and associated valuations, including the care management services, prolonged services, and other non-face-to-face services. As proposed, the inherent complexity code would address what CMS believes are long-standing issues with coding and valuation of office and other outpatient E&M services that do not fully distinguish and account for resource costs for primary care and other longitudinal care for complex patients, but specifically for visits associated with longitudinal non-procedural care when compared to work RVUs for procedural services and visits furnished in association with procedural-based care. They believe because E&M visit codes are intended to be used very broadly, the complexity of services required to provide this type of care is not fully incorporated as part of the valuation of the work RVUs when the E&M code itself is used as the primary way to report the work of the professional. In other words, while many medical professionals rely on procedural codes with work RVUs that account appropriately for their particular expertise and the intensity associated with their overall cost in furnishing care, the expertise of those who rely predominantly on E&M services to report their services is left relatively under-recognized within the previous and current E&M coding and valuation structure. So this is because E&M valuation is broad-based and the same E&M visit codes are routinely reported both alone and with many different procedural codes. And they believe that this specific gap in appropriate evaluation and coding is in addition to and not overlapping with the gaps in coding and valuation that led to the creation of care management coding, remote patient monitoring, etc. And as they understand it, those lateral codes describe services furnished and resource costs incurred in addition to the intensity and professional work within the visits themselves. So consequently, they do not believe that the inherent complexity code would be duplicative of care management services, since the inherent complexity better recognizes the professional work within the visit, while the care management codes recognize services that happen outside of the visit. And this applies, of course, when the inherent complexity code is appropriately reported as a way to characterize E&M visits associated with medical care services that serve as the continuing focal point for all needed healthcare services, and or with medical care services that are part of ongoing care related to a patient's single serious condition or a complex condition. There was another thing in here that I wanted to make mention of. And so they also said they had comments about clarifying when this code should be used. And so they said, in consideration of the many comments we received, we recognize that we should clarify when this code can be used. Specifically, this add-on code is intended to characterize the base service, that is the office and other outpatient E&M visits, based on the kind of care being furnished, medical care services that serve as the continuing focal point for all needed healthcare services, and or with medical care services that are part of ongoing care related to a patient's single, serious, or complex condition, to better account for the inherent complexity of these services that would otherwise be unaccounted for. CMS notes that the application of the add-on code is not based on the characteristics of particular patients, even though the rationale for valuing the code is based on recognizing the typical complexity of patient needs, but rather the relationship between the patient and the practitioner. They also agree with commenters who pointed out that the office and other outpatient E&M visit levels, care management codes, and prolonged service codes are intended to account for additional minutes of time or complexities for individual patients. This code should be used furnishing office and other outpatient E&M visits associated with medical care service that serve as, again, the they stress, I feel like I'm saying this over and over again, continual focal point for all needed healthcare services, and or with medical care services that are part of ongoing care related to a patient's single serious condition or a complex condition. And so, again, they want to clarify that it is the relationship between the patient and the practitioner that is the determining factor of when the add-on code should be billed. First, the continuing focal point for all needed healthcare services describes a relationship between the patient and the practitioner. When the practitioner is the continuing focal point for all healthcare services that the patient needs. For example, a patient has a primary care practitioner that is the continuing focal point for all healthcare services, and the patient sees this practitioner to be evaluated for sinus congestion. The inherent complexity that this code, G2211, captures is not in the clinical condition itself, sinus congestion, but rather the cognitive load of the continued responsibility of being the focal point for all needed services for this patient. There's previously unrecognized but important cognitive effort of utilizing the longitudinal relationship itself in the diagnosis and the treatment plan, and weighing the factors that affect a longitudinal doctor-patient relationship. In this example, the primary care practitioner could recommend conservative treatment or prescription of antibiotics. If the practitioner recommends conservative treatment and no new prescriptions, some patients may think that the doctor is not taking the patient's concerns seriously, and it could erode the trust placed in that practitioner. In turn, an eroded primary care practitioner or patient relationship may make it less likely that the patient would follow that practitioner's advice on a needed vaccination at the next visit. The primary care practitioner must decide what course of action and choice of words in the visit itself that would lead to the best health outcome in this single visit, while simultaneously building up an effective, trusting, longitudinal relationship with this patient for all of the primary health care needs. So weighing these various factors, even for a seemingly simple condition like sinus congestion, makes the entire interaction inherently complex. And it is this complexity in the relationship between the doctor and the patient that this code captures. So that made perfect sense to me. Because again, if the patient doesn't trust the doctor has their best interest at heart, one, they may not go back and see that doctor again. Two, that's when non-compliance comes into play, because I don't trust that you are saying or doing what's right or best for me. So while I'll take that prescription that you're giving me, I ain't going to fill it. And if I go fill it, I'm not taking the pills. So again, this I like how they talk about, and I think it's in this one or in another one, how they have to word it appropriately. So to me, again, I put on my public health hat. That's where some cultural competence come in, because you have to know how to speak to your patient to get them to understand, the what's best for them, to get them to understand that what you're prescribing or what you're suggesting or what you're recommending or what the treatment plan that you have decided for them would work and why. And so yeah, you can't treat every patient the same. And so you have to come in knowing and understanding, okay, this patient, and building that relationship. We've built a relationship here. So y'all know y'all can come to us to get some of the real about some of the things that happens. And that's why you come back. That's why you come to hear, and sometimes we do it in jest, we make our comments and we do, but that we've put in the time, the work, the research to kind of understand and provide you with the information that is out there so you can best prepare yourself and others in your various health information profession, wherever it is that you're working. You can share that same information and know that you got it from a reliable, trusted source. So just like the relationship between the patient, or just like our relationship, this is similar to the patient physician or practitioner relationship, because it can go for practitioners too, relationship, and how they have to build that trust. Like I have a doctor that I've been with for 30, 40 years, and I trust him, and he knows, how serious I am about holistic medicine. He knows how serious I am about the things that I put in my body. So he knows that he got to come correct with me. And he knows, no, I can't just tell her, well, you can take this pill, and I'm not taking that pill. We already know, because we have that relationship built. So he has to already come in the door having the conversations with me about how do I get her to understand, where we are and what we need to do, and some options that can best serve her in this particular case. And so this is what this code is going to pay the providers additionally for, that additional cognitive work that must happen and must go on in relationship to that. That's right. Trustworthy resources. That's right. Mrs. Jesse, you want to say something?
No.
Let me see. She said, yes, I want QHPs to show me documentation, because they're right. Most PCPs do not care. Sorry, not sorry. But exactly. She said, doctors sure need a class in med school for how to communicate and foster a trusting relationships with their patients, and not just treat patients like cattle. Exactly. And just giving out prescriptions just cause, nah, doc, nah. So this, again, there has to be documentation. Oh, wait, I'm looking at some other stuff, craft code. I'm gonna have to come back to you on that. But again, I think this, there has to be that documentation. And so the documentation of that interaction has to be in that visit. But then there should be other documentation from other visits, because this won't be for every visit. This will be for those visits where something comes up, and yes, this cognitive work has to be displayed in this particular visit. But you should be able to see the relationship build from visit to visit, as you get to the particular visit where you have to add the add-on code. So that was one example that they had related to that. And then there was another one for a patient. It says the second part of the add-on code also describes a relationship between the practitioner and patient, but for specific types of conditions. So yeah, that first one was just kind of the sinus congestion. It isn't a large clinical condition by itself, but because of building the relationship with that practitioner and that patient, it makes it important that the information and things that that physician provides to that patient, um, based on their relationship, will help with, like they said, well, the next visit he may have to say, hey, I need you to get a shingles vaccination. And because y'all have this relationship and he knows how you feel, he or she knows how you feel about whatever, they can trust that him saying, okay, yeah, you need to get this shingle vaccination, they can trust that that is the right course of action and the right thing to do for them.
So
But this, go ahead.
I do have a question. So
Okay.
how does this fit into the whole time criteria for visits? And if you have, like, because this extra see, it sounds to me like um more time is being allotted, and I thought that they already had a mechanism in in E&M for you to, and especially for counseling. So, because this is what it is, this what it really sounds like to me.
Yeah, sort of. Counseling, well, because there was the once upon a time, the information based, you can use time based on counseling and coordinating care.
Hmm.
The way the medical decision making codes are broken down now, that's not necessarily the case. So you're using the time to show what your medical decision making, what you reviewed, what you looked at, what you assessed to determine what the outcome is for that particular visit. This one, and that's still the case. So you would base your base E&M code on that. But this extra add-on code is the additional piece, because you're managing all of the other, you're the person, you're the physician that's managing all the other pieces related to this patient. So again, part of being able to use this code is you, doctor, practitioner, is the one responsible for all the other stuff. So not just this one-off condition, or one-off, you the specialist on one-off. You're responsible for all the things that happen, including this. And so you're building that relationship. So if I tell you, hey, you know, you have diabetes, and we believe that the course of action, because of your A1C and the numbers that we're seeing in your blood sugar and all of these things that could potentially, and say you're newly diagnosed, let's start there, you're newly diagnosed, and you have they're seeing some labs that suggest that there may be some kidney interaction with your diabetes. And so you are talking to this patient to get them to understand what all that looks like, and that they may also now have to see a kidney specialist, and that you will be working with this kidney specialist to make sure that the medications and the prescriptions and all of the things that they may recommend for you and suggest for you is for your good. And so it's one thing to say, okay, patient, here's a typical patient, and this is how we treat them. We give them this, we start them on this, we start them on this. But you have to look at this is a way to look at your patient as an individual coming through the door, and understanding and knowing there may be other things going on, social determinants of health. There may be things outside of what's happening that this practitioner knows about this patient because of the relationship they build, that may say, okay, I know that we're going to have to get this patient into seeing a kidney specialist, but they don't really have transportation. And so adding an additional doctor visit may not work. So how do I work to make sure all of that happens? Now, part of that would be outside of the visit, because that can be part of the chronic care management piece, which is an additional E&M code. But inside the visit, you got to think about, how can I relay this to this person so they understand that I'm working in the best interest of who they are and what they come to the table with. Does that make sense?
Yeah.
Okay. So the other part, it was for medical care services that are part of ongoing care related to a patient's single serious condition or complex condition. And this one, the example was a patient with HIV who has an office visit with their infectious disease physician, who is part of ongoing care. The patient with HIV admits to the infectious disease physician that there have been several missed doses of HIV medication in the last month. The infectious disease physician has to weigh their response during the visit, the intonation of their voice, the choice of words, to not only communicate clearly that it's important to not miss doses of HIV medication, but also to create a sense of safety for the patient in sharing information like this in the future. Because if we feel in some kind of way, we ain't letting you know. Let's be clear, especially for folks that look like us. They don't want to be there in the first place. So they going to be like, yeah, everything's good. So to build the relationship, it's a two-way street. So they got to give and you got to give. And you got to feel comfortable enough with this physician, whether they look like you or not, because it's your physician, to share with them all of the things, because they can't help you if they don't know everything that's going on. So you got to be able to share all of these things. So again, this is about this extra code is about the work that they have to do to build. Look, they paying them extra to date you, because you got to know what you're dealing with. In essence. So it says to clearly communicate that it's important to not miss doses of HIV medication, but also to create a sense of safety for the patient in sharing information like this in the future. If the interaction goes poorly, it could erode the sense of trust built up over time, and the patient may be less likely to share their medication adherence shortcomings in the future. If the patient isn't forthright about their medication adherence, it may lead to the infectious disease physician switching HIV medicines to another with greater side effects, even when there was no issue with the original medication. It is because the infectious disease physician is part of ongoing care and has to weigh these types of factors that the E&M visit becomes inherently more complex, and the practitioner bills this code G2211, even though the infectious disease doctor may not be the focal point for all services, such as in the previous example. HIV is a single serious condition and or a complex condition. And so as long as the relationship between the infectious disease physician and the patient is ongoing, this E&M visit code could be billed with, or the E&M visit could be billed with the add-on code G2211. So yeah, there was a whole lot. And then somebody came back with some examples, and they were just using examples of certain conditions. But in the examples that they provided, CMS corrected them and said, well, you're not showing the relationship. And again, that is the primary piece to being able to add on the code, is showing the relationship between the practitioner and the patient. So that was that. Look, I took a whole lot of time for that. Any questions? Look, I see a whole bunch of stuff. Let me real quick talk about the and this will take like a couple minutes, because I did want to talk about this split shared service piece and what they changed in relation to that. Where is it? And Mr. Jesse, you can tell me good comments that I need to show.
Okay, well, you know, the crafty coder
is always on. Oh no. So this was all information about, they talked about being more regular and evaluating E&M codes as well. So the split shared service visit refers to an E&M visit performed by both a physician and an MPP in the same group practice. In non-facility, for example, office setting, the rules for incident to billing apply under the circumstances. However, incident to services are not available for services furnished in a facility setting. So longstanding CMS policy has been that for split or shared visits in the facility, for example, the hospital setting, the physician can bill for the services if they perform a substantive portion of the encounter. Otherwise, the MPP would bill for the service. And there are some reductions. So if the MPP bills for the service, they are paid for the services they perform, that they furnish and bill for at a reduced physician fee schedule rate of 85%. Whereas if the physician provides the service, they are billed or they are reimbursed or paid for it at 100%. And so that's where the difference is with understanding how to use split share services. So what they wanted to do was define substantive portion of the visit. And in calendar year 2022, they proposed, they finalized a phased-in approach to this policy. So they finalized the definition of substantive portion as one of the following: either one of the three key elements, that is history, exam, and medical decision-making. Again, this was before the changes of facility E&M, or more than half the total time. They also stated that they would delay the full implementation of the definition of substantive portion as more than half of total time until calendar year 2023 because of all of the things that was going on. And then they were also proposing to create a payment modifier FS, to describe split or shared visits. And then over time, implementing and using this modifier will better enable CMS to quantify split or shared visits and better understand the billing patterns of practitioners that typically furnish them. And so such information is helpful to CMS for program integrity purposes and may also inform us of whether we need to clarify or further revise the policy for these services in future rulemaking. They have roughly 1 year's worth of claims data from the time they implemented the modifier as part of ongoing engagement with interested parties. And they have continued to hear concerns about their intent to implement our policy to use more than half of the total time to define the substantive portion of a split shared visit, and have received requests to continue to recognize medical decision-making as the substantive portion. Many of these concerns specifically reference disruptions to current team-based practice patterns and the potential for significant adjustment to the practice internal processes or information systems to allow for tracking visits based on time rather than medical decision-making. So they finalized a policy to delay the implementation of their definition until January 1 of 2024. And then after much consideration, they proposed to delay the implementation of their definition of substantive portion as more than half of the total time through at least December 31st, 2024 for the same reasons outlined in 2023. They are proposing maintaining the current definition of substantive portion of for calendar year 2024, which allows using any of the three key components: history, exam, or medical decision-making, or more than half of the total time spent to determine who bills the visit. We stated that the additional delay would allow interested parties to have another opportunity to comment on this policy and will give CMS time to consider more recent feedback and evaluate whether there is a need for additional rulemaking on this aspect of our policy. We express interest in how facilities currently implement our split shared services policy in their workflows and how facilities now account for billing practitioner services that are performed split or shared. They express interest in better accounting for the billing practitioner services in team-based care clinical scenarios. They also recognize that the AMA CPT editorial panel was considering revisions to aspects of split or shared visit in calendar year 2024 that may impact our policies, but those changes had not been finalized before our proposed rule was published. We stated that we would review the AMA CPT editorial panel's changes to split or shared visits when and if available before the final rule, and in the context of our policy proposal. We indicated that we would consider any changes that are made by CPT and their relationship to our previously finalized policies, and whether a further implemented delay beyond calendar year 2024 or revision of the definition of substantive portion is warranted. We propose to amend section 415.140 to delay implementation of the definition of substantive portion as more than half of the total time through calendar year 2024 in the interim, while we continue to analyze and collect information from interested parties and commenters as whether we should permanently modify our current definition. And so they got all kinds of feedback related to that. And something they said, we define a split share visit as an E&M visit in the facility setting that is performed in part by both a physician and an MPP who are in the same group practice in accordance with applicable laws and regulations. We note that the policy is not about whether the physician's expertise is, quote, necessary for the visit, but rather whether the physician or the nurse or the non-physician practitioner should bill for the service when each of them are performing part of an E&M visit. A few commenters urged to withdraw the substantive portion policy and continue using its current history, exam, and medical decision-making policy, and do not believe that over half is an appropriate definition of substantive portion for the purpose of paying for split shared services. They said they appreciate the commenters' concerns, and will continue to consider the potential impact of our policy on rural or health professional shortage areas for future rulemaking. So yeah, I think that they have some commenters are asking them to push it out further until January 1, 2025. I think they done put their 10 toes down in the sand. And this is what they're going to do. But they are asking, I think, for more. They did want to say, they note that the CPT editorial panel recently issued its revised guidelines for split or shared visits for calendar year 2024. Specifically, the editorial panel changed the definition of a split or shared visit to refer to the substantive portion of a service as either more than half of the total time spent by the physician or MPP performing the split shared visit, or a substantive part of the medical decision making, and to indicate that these guidelines should be applied to determine whether the physician or MPP may bill for the service. For calendar year 2024, the CPT E&M guidelines for billing split or shared services now state that physicians and other qualified health professionals may act as a team in providing care for the patient, working together during a single E&M service. The split or shared visits guidelines are applied to determine which professional may report the service. If the physician or other qualified health care professional performs a substantive portion of the encounter, the physician or other QHP may report the service. If code selection is based on total time on the date of the encounter, the service is reported by the professional who spent the majority of the face-to-face time or non-face-to-face time performing the service. For the purpose of reporting E&M services within the context of team-based care, performance of a substantive part of the medical decision-making requires that the physicians or other QHPs made or approved the management plan for the number and complexities of problems addressed at the encounter and takes responsibility for that plan with its inherited risk of complications and or morbidity or mortality of patient management. By doing so, a physician or other QHP has performed 2 of the 3 elements used in the selection of the code level based on medical decision-making. If the amount and or complexity of data to be reviewed and analyzed is used by the physician or QHP to determine the reported code level, assessing an independent historian's narrative and the order or review of tests or documents do not have to be personally performed by the physician or other QHP because the relevant items will be considered in formulating the management plan. Independent interpret. Go ahead.
Question.
Yes.
How does all how do you get to figure all that out when every note has been copied and pasted?
Wait a minute. How you go? Unfortunately, you only have, just like in determining, all you have is the documentation that they provide. So if they have copied and pasted over and over again, for that particular, because you're only coding for that particular encounter, you use that encounter information. Now, if you want to audit to show that we have a problem with a provider copying and pasting from visit to visit, then that's a secondary kind of check or look and to say, okay, here's the problem, because oftentimes it's contradictory to some of the things that you said that you needed to do based on your medical decision making, because those things don't even exist anymore. They're not using that medication anymore. You changed that medication in one of them, and now you're copying and pasting and telling us something. I mean, so it's usually uncovered if you do a visit by visit check of what has been copy and pasted. There's usually some error. Now, if they're treating this patient the same every single time, and only thing they're doing is changing the date and time that they see them, that's a whole other problem. And again, that's something that should be addressed by either management for those providers. Now, if they're working in their own little world, in their own practice, then that's kind of hard to uncover and hard to have to solve, because again, this is how we work, this is how we do it, and you kind of stuck. But if you are in a position to show management, well, hey, this doesn't make sense, or show them. And if there's a medical director that you can go to where you can have those conversations, who will then be the liaison between the two, that usually helps as well. So it's hard, but at the end of the day, you only have the documentation that is in front of you for that particular visit for you to determine. And most of us, anybody who knows E&M can say, "Oh my God, what is this?" You can see it. It's blatant. You don't even need a whole bunch of charts to determine who and what has succumbed to those types of practices, if you will. Okay. Oh Lord, I don't even know where to start with her. He didn't know about him. See the hospital. He should. Meanwhile, the patients in the hospital only see the physician maybe a total of an hour throughout a 7-day stay. They got to do better. Hopefully that changes to help with the compliance more. I'm trying to see where she modify it. Just do it so they know you are serious. You cannot ask someone to do something and never check back up on what you were expecting. Exactly. Why push back? You've had 15 years to have a buffer to get it right. And they pretty much bullying the coders to be non-compliant. And it's always, oh, we don't want to make the doctor such and such mad. Yeah, that's horrible. Yeah. But then, so we talked about that last time. Where's my whistle? Where is my whistle? Oh, it's downstairs. We talked about that last time. So yeah, I know that was a mouthful. Look, there probably was like 2 whole other additional. If I find some more stuff, I'll post it, or I'll do a separate video on the complexities of both of those. But I hope that gave you just a bit of understanding. I'm sorry. She said my brain is about to explode. I needed a whole pot of tea. My bad. But I hope that gives you some insight into the complexities of what we have signed up for as health information professionals. These are the things you need to know. You need to understand so that you can help your facilities, you can help your physicians, you can help your other qualified healthcare providers in understanding the rules and regulations as it relates to payment, documentation, and all of the things for the services they provide, and so that they can get paid and keep the money that they're getting paid. So it's all part of what we have to do and what we need to know in order to do that at the end of the day. All right, I did a lot of talking. Look, I didn't even get to drink my tea. Mr. Jesse, did you have anything else you want to?
I just know that anybody who orders E&M, they're going to be very busy.
I love E&M. It's my favorite. I mean, I liked it even when it was all the other stuff. It was, but I was real clear that back in the day, those practitioners, you couldn't just check off history and exam and think he was going to get that level. No. I had to see medical decision making. That was one of the things. And I would get pushed back all the time, but I would 10 toes down. No, ma'am, no, sir. I'm not giving you the credit for that. And then especially when the EMRs came into play, when it was just an easy, this, check, click, and copy, cut, paste, and all of the things. It was a mess. So yeah. All right. It says help yourself as well. Exactly. Well, I guess we are at the top of the hour. Thank you all again for joining us. The Saturday morning tea. It was a lot. I do agree. Now that, but I got caught up and because there were some other pieces and I was like, there is no way I can do all of that in an hour. But I get caught up. But this is the things that, can you tell? I love dissecting and reading and understanding the reasons why. We talk about this before. You got to know the reasons why you're doing some of the stuff that you're doing. And this right here is regulation. This right here is policy. And this is the reason why you have to do what you have to do. You have to document the way you have to document in order to get paid. This is the reason why. So thank you all for indulging me on a small business Saturday. And if things like this interest you and you want to come on and join us over in the Patreon, feel free to check out the link in the description box. Feel free to support our efforts in providing you with the additional information and skills and entrepreneurial tips and all the things that you need to be successful. Am I boring you, sir? No, all the things, I'm kidding. All the things to be successful in your career. So come join and be part of the Patreon because we got some serious meeting after the meeting discussions happening today. All right. Was that a good enough plug for today? All right. So was the tea spilled today? Was it spilled today? Well, hopefully it was. I think so. Yeah, thank you. A lot of tea today. She had a whole pot of tea, all of the things. Piping hot tea. Love it. All right. So if this information was valuable for you, help us share this message with others by sharing the video or telling somebody. If you tell your friends, we just talked about relationship building. You tell somebody who tells somebody, have them come out. Now, if they can't join us live on Saturday morning and it's not convenient, that's okay. The replay is out there. They can always go back and check out the replay, make comments, join the conversation, all of the things. I check it regularly. So have them check out the replay if they need to, and subscribe to the channel. Now, clearly, I'm not going to meet my goal of 10,000. However, I am very close to 5,000. So let's let's get there. And then, I'm still pushing for my 10 and 20,000. I ain't playing with y'all. I still have that goal, and Lord willing, we're gonna meet it. Also, be sure to follow us for more information on all things health information, compliance, revenue cycle, and medical coding. And as you leave, don't forget to hit the thumbs up or like button. Also, check out my co-host. He has a channel, the Coding Nurse channel on YouTube, where he spills gems as well. So check out the information there, particularly from a diagnosis perspective. This has been a great session. Thank you all for joining. And remember, be safe, be kind, and don't wish for it. work for it. I hope you had a wonderful Thanksgiving. I hope you don't spend up all your money. And we'll see you, I believe.
And
Go ahead.
the takeaway that I want everybody to leave with today is there is a whole bunch of money to be made in E&M auditing. If you're at all interested, with all that convolution we just discussed, there's money out there.
And we're showing you how to get to it. So join us on the Patreon, the meeting after the meeting. We'll see you in 5 minutes. All right. Thank you.